Behind every safe surgery stands a team working quietly behind the scenes. Anesthesiologists safeguard every breath, every heartbeat, every moment that matters. The essence of anesthesia is walking a tightrope between controlled unconsciousness and unpredictable crisis. No one knows what the next second may bring. Malignant hyperthermia, anaphylactic shock, airway collapse, or cardiac arrest. When a crisis strikes without warning, experience, protocols, teamwork, and instinct come together to determine the course of a life. Bangkok 2026. 10 elite anesthesia teams from across Asia and Australia step onto the same simulation stage. Through scenarios that mirror reality as closely as possible, they will relive the most critical moments ever faced in the operating room. This is not a contest about winning or losing. It is a collective rehearsal for the front line of life itself.
Events aim to share new research, update clinical techniques and knowledge, and also to enhance patient safety, and of course to strengthen collaboration amongst the anesthesia professionals in Asia and Australia.
Through such critical academic exchange activity with the top global platform, Coleman continue to deepen our clinical center's value, actively engage in real medical scenarios, and contribute our professional expertise to enhance anesthesia safety, improving healthcare quality and addressing clinical challenge. That is one of the reasons that we host the competition today. Co-Anesthesia share with the world.
Each team's performance will be assessed across 5 key dimensions: case design, clinical guideline compliance, technical proficiency, team communication, and the quality of debriefing. The first team to take the stage represents Zhongshan Hospital, Fudan University, China. They are confronted with a highly deceptive perioperative crisis. Familiar clinical signs may conceal an entirely different underlying cause. When experience and clinical judgment are put to the test, only a systematic approach can lead the team to the right diagnosis. TURP syndrome is one of the most dangerous complications in urologic surgery. It is a classic scenario found in every textbook, yet one of the most easily overlooked traps in clinical practice.
You can see mosaic pattern in the LVOT. It might be same. We need to change our strategy. Increase the IV fluid now.
Okay. Mission impossible. That kind of saying is not quite accurate for us because our job is to access the patient's different conditions, figure out the specific dangers, and then create a relatively safe plan. We didn't rescue or save her in one moment. Instead, build a step-by-step plan to reduce the risk.
But when crisis strikes, we must become the most reliable existence in the OR. Anesthesiologists are like walking a tightrope on a cliff edge, requiring precise judgment of every moment of change. The job is challenging.
Because it could be dangerous to run norepinephrine at a high concentration peripherally in case of tissue extravasation. So just as a learning exercise, it's a very important management skill that you did, and we congratulate you.
Representing Marengo CIMS Hospital, India, this team brings with them 15 years of excellence in cardiac anesthesia. From heart transplantation to cardiopulmonary bypass, the extreme scenarios recreated in this competition mirror the very crises they face every day. Persistent hypotension of unknown origin remains every anesthesiologist's nightmare, demanding a systematic diagnosis within minutes. And in those critical moments, transesophageal echocardiography, TEE becomes the anesthesiologist's third eye.
Oh, BP is just 60/30 and cardiac index is 1.2. Shreya, give 1 milligram of bolus. Oh, I can see a flap in ascending aorta.
Oh, you mean aortic dissection?
Oh yes, doctor, there is acute aortic dissection. Look at the echo. We need to fix this as soon as possible. We need to go on urgently on CPB. Shreya, give 10,000 units of heparin straight away.
Yes, sir.
Lisa, you please prepare the right groin area.
So there is vast difference between textbook anesthesia and in real operation room. We all read about difficult airway and difficult intubation protocols and guidelines in detail, but in reality, when you are facing the patient and an emergency situation, it is quite different.
Nicknamed by the judges as the Thai Boy Band, the team from Konkan University brought the agility and energy unique to youth, adding a refreshing spirit to this intense academic competition.
Oh, his jaw is more stiff. The intravenous carbon dioxide rapid rising.
The temperature is 38.5 degrees Celsius. I think this could be a sign of malignant hypothermia. Could you
Malignant hyperthermia is a rare but life-threatening inherited muscle disorder. Triggered by volatile anesthetic agents and succinylcholine, it causes a rapid hypermetabolic crisis involving the entire musculature. Without prompt recognition and treatment within minutes, mortality approaches 100%. It is the ultimate test of a team's speed, workflow, and coordination.
I'll turn off Sivo rain, increase the FiO2 to 100%, flush the circuit with a very high flow, increase minute ventilation. So it's going to be VT with the pulse according to the guidelines. We should start with amiodarone.
Okay.
Nurse, could you get it?
Okay. Do you want a defibrillator?
Yeah, prepare defibrillator as
will
well.
prepare it.
So please give me 150 milligrams of amiodarone and give it to me, please.
I think
let's
he
check.
still have the muscle rigidity, Dr. Ben.
I agree. I think he still has a very rigid muscle. So, and the vital signs are still very, very viable. So, should we repeat the second dose of dantrolene bolus?
Okay, I agree.
Okay, so it's going to be 2.5 milligram per kilo equal to 150 milligram again.
Okay, I see. Do you need a Foley catheter?
New team. That was a really well structured scenario, clearly demonstrated with lots of good learning points. I particularly like the way you demonstrated the use of the MH protocol checklist, because it is quite a complicated scenario, so a checklist is very helpful.
It was very nice demonstration, good team report, good communication skill. And you didn't forget to put the Foley's catheter at the end. But would you...
Competing on home soil, the team from Siri Raj Hospital, Mahidol University, showcased exceptional professionalism and flawless teamwork. Faced with sudden maternal hypotension, they remained composed, trusted the data before them, swiftly identified the underlying cause, and made the right clinical decision within moments.
Now the blood pressure is down, 60.
Okay, we're not doing that great.
You started with the basal just now.
Okay.
Can you go up on the basal and then we will need to go up on the norepi as well. Start the norepi now.
Okay.
I think you can you reclaim the portal vein for us, please?
I could, but I don't want to. I mean, it's going to prolong the surgery. The valves will get more congested, and I'm sure you can do something else rather than I'm putting on the background.
Okay, and I understand your concern, and it's very valid. But the priority right now is that the patient is tanking. And
I think the biggest responsibility for us is to know, to be aware of the fact that the patients place their trust upon us in their most vulnerable moments. Surgery can be stressful for everyone, and to be able to know that someone is willing to entrust their lives upon us is very important. I see my mentors do things systematically. They have situation awareness. They anticipate things that will happen, and they remain calm under pressure.
Please take a look at the RV for me, please. So right now I'm at the mediasophysial for chamber view right now. The RV is dilated, and after the color Doppler on, I see some TR as well. I
Okay.
think RV is not good.
All right, agree. Can you show me the left ventricle too?
For the left ventricle, I think it's a little bit underfilled. Anyway, no dynamic aortic obstruction and no L thrombus in the heart or the PA.
All right, perfect. So Jason, Nick just identified an RV failure on the echo here. I think that we are looking at a severe vasoplegia from the reperfusion, and he had a pulmonary hypertension in the pre-op, so probably that triggered a pulmonary hypertensive. Jason, it's not a drill. Okay, the power is out. The power is out. It is not a drill. And I can hear my oxygen cylinder alarm. Like the oxygen supply is cut. Okay, guys. Nick, can you check the oxygen if it's working?
Yes, just like
Please be careful.
I think it's a very interesting case, and you managed it very well. And you also mentioned about limited resource regarding TE. So
Congratulations, Team Suriraj. That was a very complicated scenario, but the standout learning points for me related to communication, and I think especially the communication from Rachel to Jason. It was, I think, an example of graded assertiveness. She's very clear.
Communication is the soul of teamwork. Throughout the competition, the Malaysian team demonstrated almost flawless closed-loop communication. Faced with the complexities of managing anesthesia for a morbidly obese patient, the team starts with a structured preoperative briefing, builds a shared plan alongside the surgeons, and sustains clear communication as the crisis unfolds. Every decision is guided by the same understanding. Every action is driven by the same goal.
So we're going to do a case of laparoscopic sleeve gastrectomy, and the patient is morbidly obese, all right, and also have obstructive sleep apnea, and we anticipated difficult airway during our pre-op assessment. Mr. Don, can I know what sound is that?
I think there's a bleeder over the splenic vessels, I think.
The blood pressure is dropping.
Alright.
Jennifer, can we please up the colloids and crystalloids and run bolus? Oh, yeah, that's quite a lot.
Okay.
It's already 3 liters.
Feed is not good. I'll convert to open right now.
Okay, very good.
Okay, converting open.
I stood up and I looked at the surgical field and I said, it's bleeding. The monitorings on the screen actually tells us a story. Monitorings are not just numbers. They tell us what is happening to the patient. Can we please get more blood? I need the blood to be in now.
Okay, I'm calling the blood
Okay.
to activate them.
I also might need the massive transfusion protocol to be activated soon. Okay. During this period of time, can we please keep the temperature normal? Okay. The patient there's no acidosis, no coagulopathy, and also look at the calcium. Have my ABG come back, please.
Okay, I got secured the bleeder.
Doctor, this is your ABG.
Alright.
It shows metabolic acidosis, increase in lactate and sugars.
Yes, can we just start some insulin, about 3 units per
This is the
hour?
insulin.
We will push the patient to the ICU. Okay, and I will like to have a debriefing with all of you. Okay, Jennifer, how are you feeling now?
I'm feeling so upset
So upset, why?
because I can't even get a line.
Don't worry, we will provide more training. Ultrasound is here.
Yeah, I
Alright.
think I need to attend the course.
Yes. Okay, Mr. Don, what? Are you okay?
Today was unfortunate, but
It's okay.
But I'll do better tomorrow.
We do better.
We do better.
All right.
All right.
Thank you. Okay, done.
Fabulous work. Really felt like I was in the operating room. I think it was a very simple case, but there were very subtle suggestions that there was a lot of detail taken into consideration. I really liked the way you managed the airway. You thought through problems at the time, you rechecked tube, you listened to the chest. These are very nuanced observations which I thought were done very well. Most importantly, I really was impressed with the anaesthetist. Just really great, a great culture in the operating room, made everyone feel relaxed, and for me, the scene flowed very well because everyone felt psychologically very safe, and I think there's a lot to be learned from that, so congratulations.
Thank you. Thank you.
Excellent presentation, and we want such anesthetists in all the OR, who is so interactive with the surgeon and the team.
Pediatric congenital cardiac anesthesia is regarded as one of the greatest challenges in anesthesiology. The Saudi Arabian team was caring for a child with a single ventricle physiology. In these patients, even the smallest change can determine the outcome.
Okay, this patient will go for bilateral inguinal hernia repair.
Is it laparoscopic or an open approach?
Laparoscopic.
Pressure is 12. Something is wrong. Patient is desating, heart rate and peak air pressure are rising. And also the end-tidal CO2 is increasing. Actually, I think this is most likely gland flow impairment, but we need to exclude the other causes. Dr. Balqis, 80 ml crystalloid given. The circuit is patent. Tube is not king and remains at 10 centimeter. There is no compression over the jugular vein. Exposing the chest, there is no rush. Let's auscultate to see if there are any added sound. There is equal bilateral air entry. No wheezes or other added sound. Can I have the section? Dr. Balqis, by the way, pressure is 12. No secretions. What? Pressure is 12. Really? Dr. Mohab, deflate the abdomen immediately and
Sure,
level
sure.
the bed, please.
Okay, abdominal bleed deflated now.
Abdomen deflated and bed is leveled. Let's obtain an ABG.
Yeah, great. I think very complex patient, and again, really impressed by the calmness in which you managed this infant. I thought that the communication was excellent, and I thought the correct clinical decisions were made in the best interest of the child. Nice to see such good communication between the entire team.
Representing Xuanwu Hospital, Capital Medical University, this challenge is a test of observation and clinical judgment. Not every crisis begins with dramatic physiological collapse. Sometimes it starts with a subtle change on the monitor, a signal that is easy to overlook. The team that recognizes it first gains the opportunity to change the outcome. That is the challenge awaiting Team Xuanwu.
Blood pressure is dropping. Speed up the fluid. Okay. Give phenylephrine 100 milligram IV injection.
Phenylephrine 100 milligram.
Phenol response. Repeat phenylephrine 100 milligram.
Okay, another phenylephrine 100 milligram.
Okay, still no response. Patient has extensive flushing all over the chest. Suspects anaphylactic shock. Call for help immediately.
Okay.
Prepare adrenaline 100 microgram per milliliter.
Okay.
And methylprednisolone 160 milligram. I'll intubate now. Start chest compression.
Okay.
Give adrenaline 1 milligram IV injection.
Without those comprehensive monitoring, I might have wasted valuable time to check for other causes. The delay of a proper treatment may potentially lead to more severe complications or cause irreversible damage.
Excellent case, and when I heard at the last of the case that it was a real case,
yes,
I was moved.
Thank you.
Philippine General Hospital presents more than a challenging crisis scenario. Their focus is a complete cycle of crisis management, from preparation to teamwork to reflective debriefing. Outstanding teams do more than overcome a crisis. They learn from everyone.
Our machines are alarming. It says high airway pressure. What's happening?
Okay, what's happening? Anesthesia, I'll stop the biopsy now.
Echo is dampening.
This is dynamic airway collapse.
His oxygen saturations are dropping. Now
the
70%.
I'm meeting resistance. The lumen is still collapsing.
His lips are turning cyanotic.
This looks like extrinsic compression.
The patient
The
is
armored tube
crashing.
won't be able to bypass. Should we proceed with plan B, anesthesia?
Agree.
Okay, let's do rigid bronchoscopy and prepare now.
Please give her coronium now. Are you sure? You said no muscle relaxants before.
Yes, this will improve airway dynamics. Can you move faster, please? I'm about to insert the scope.
Aspirating rocuronium. Doctors, the BP is dropping. He's
Oh no, what's happening?
hypotensive.
Secure the airway first with an ET tube.
He's turning bradycardic at 60.
Nurse?
Cardiac index and systemic vascular resistance
Stop
are also
panicking,
low.
please. Should we proceed with plan C and go on mechanical circulatory
Starting more
support?
epinephrine
Yes,
now.
let's go.
Can you access the femoral now?
Thankfully, the monitors were clear and reliable, which helped me quickly recognize the problem and act decisively while staying calm. If the data hadn't been as clear, I would have relied more on clinical science and teamwork to safely manage the situation step by step.
I think you need to move a bit faster, doctor.
What do you think I'm doing? I'm doing my best. Why don't you just do your job?
Everyone calm down. We are prepared for this. We have the plans, okay? Let's go on bypass now.
Okay, cannulation is complete.
Yeah, it's really a very challengeable cases, and we are happy to see the battle between the anesthesiology and the surgery. It's really a real scene.
Traveling all the way from Moscow, the Russian team presents one of the most challenging crises in obstetric anesthesia. Confronted with massive postpartum hemorrhage, repeated cardiac arrests, and a cascade of life-threatening complications, the team must fight through one life-or-death moment after another, restoring circulation and restoring hope. This is more than a test of clinical expertise. It is a test of resilience, teamwork, and the determination to never give up.
3 minutes after delivery, patient had motor agitation and anxiety, unresponsiveness to verbal contact, acquired cyanosis.
Patient is unresponsive, acquired cyanosis. Saturation is dropping. I think it's pulmonary embolism. Maria, could you bring focus, please?
What's happening? I think it's local anesthesia, systemic toxicity.
Oh no! Look at that. No thorax, no pulmonary hypertension. It's amniotic fluid embolism.
First cardiac arrest, asystole CPR.
Okay, CPR.
Epinephrine 1 mg intravenously performed.
The amniotic fluid embolism is a rare catastrophic syndrome characterized by the sudden onset of acute hypotension or cardiac arrest, severe hypoxia, coagulopathy leading to massive hemorrhage. Core management strategy: immediate resuscitation, hemodynamic support,
Defibrillation,
coagulopathy correction, immunodilation, advanced support.
Sinus rhythm.
Second cardiac arrest, asystole CPR. Third cardiac arrest, asystole CPR. Following stabilization, the surgical hemostasis was attempted. Ligation of uterine vessels, bi-Lynch compression sutures. Fourth cardiac arrest, asystole CPR.
Oh, free blood in abdominal flanks. Source: left hepatic lobe rupture and hematoma. Intervention: hematoma evacuation and left hepatic lobe suturing. Uterine stays atonic. Need hysterectomy. Activating massive transfusion protocol. Fresh frozen plasma 2 units. Red blood cells 3 units. Cryoprecipitate 10 units. Proton packs complex.
The duration was 160 hours. And the results: on day 5, she was extubated. Alone, we can do so little. Together, we can do so much. Our team, FE1.
One team, one moment, one decision.
Это пациентка, которая было несколько остановок кровообращения, другие осложнения, и когда мы думали, что буквально уже ее жизнь утекает сквозь пальцы, я не буду вам рассказывать полностью, чтобы сохранить интригу. И на самом деле мы смогли спасти эту пациентку, мало того. И в очередной раз я понял, что и невозможное возможно, и на самом деле вся наша специальность постоянно состоит из этих случаев.
When conventional solutions begin to fail, clinical expertise is measured not by instinct alone, but by the ability to remain composed and think systematically under immense pressure. Confronted with a rapidly deteriorating airway, Team Indonesia never lost control. Trusting established protocols, they advanced one step at a time, bringing the crisis steadily under control.
Wait, fight back. Airway pressure is so high. Okay, I will proceeding with intubation with video laryngoscope using Salah technique. Suction, please. Suction ready. Okay, suction ready. Please give the patient 50 mg of ketamine and 100 microgram of fentanyl. All right, inserting 50 milligrams of ketamine and 100 micrograms of fentanyl. Laryngoscope in. I see the cords. Tube in.
Wait. What is it?
Oh my god, the ETT has gone through the neck wound.
This is a trachea rupture, everyone.
You might be hurry because if we not, the oxygen will be dropping.
Okay. Oral intubation won't be successful. I will abandoning for the next oral attempt. Okay, I'll intubation from the neck wound, tube in.
Wow.
Oh my god. Okay. Connecting to manual bagging.
Whew.
Confirm tube position.
I will inflate cuff.
Securing the ETT at 14 centimeters at the neck wound.
Okay, ventilator is set.
We are definitely need to secure oral airway surgery. But I can perform the surgery if there is endotracheal drop in the trachea. Anesthesia, do you have any plan to secure the surgery?
Okay, let me think. Okay, I have an idea. We will treat oral tube over bougie. You will treat the bougie distally and I'll catch it from above, okay?
Sounds good. I'll control the distal end. And also, the EVAS is clear. I'll go to the OR. Please call the OR. Right now, I'm passing the bougie into the distal defect of the trachea.
I will treat the ETT over bougie.
I was very panicked, but I followed the algorithm and we prepared for an emergency front of neck access. When my senior arrived and secured the airway and the plethysmography waveform returned, it was an enormous relief.
I think I'm almost done.
Just as the crisis seemed under control, a new emergency emerged. By systematically excluding equipment failure and recognizing a pulmonary air embolism, the team once again brought the patient back from the edge.
Wait a minute. ETCO2?
Doctor, I think ETCO2 is dropping, Doc.
Oh my god, ETCO2 is dropping. Blood pressure is falling. Saturation now only 90%. Please increase the fraction to the 100%.
Okay, fraction increase to 100%.
How about the surgical field, Doc?
There is no bleeding in here right now, Doc.
Okay.
Please.
I will running the dope check. Tube secure. Please dissection. Lungs clear. Equipment still functioning. Okay. I think the most consistent cause for this patient is air pulmonary embolism.
Structured thinking and asking for help early will help to give the patient the best care that they will have. To be most valuable is an emotional control throughout the operation. Once we are calm, a calm anesthesiologist will keep the whole team calm, including the surgeon.
A truly meaningful competition is about more than performance. It is a bridge connecting nations, ideas, and experience. When anesthesiologists from around the world come together with a shared purpose, competition becomes a platform for learning, collaboration, and progress. That is the vision championed by the World Federation of Societies of Anesthesiologists.
Therefore, the significance of today's simulation contest cannot be understated. And through simulation, they will demonstrate not only clinical knowledge, but also communication, leadership and resilience, skills that are essential in every operating room worldwide. Thank you, judges, for your expertise, for creating this meaningful educational opportunity. And for participants, I hope you will give your best, learn from each other, and build connections that will last beyond today.
I hope they work in systems that are safer, fairer, and more supportive than what we had before. I hope they never have to choose between doing what's right and what is possible. And I hope organizations like AACA continues to connect the people.
I think this is a very interesting opportunity for us. As a clinician, as an educator, my interest is in simulation and crisis management. The environment in anesthesia is always dynamic and high stakes, and we face critical events daily. And this competition is very timely and beneficial in promoting our advocacy. So we are very grateful to the organizers and our sponsors, and the least we could do is to really prepare.
As a team, we are looking forward for new opportunities and connecting to a new network of people across the border so that we can learn something new, new innovations, new technology, and expand our horizon of practice in anesthesiologists beyond the current era and in a future trend.
A competition may last only a few short hours, but the connections it plants can continue to grow over time. What we witness is not just a contest among 10 teams, but the birth of a new model, bringing together the innovation of industry, the clinical wisdom of academia, and the spirit of research onto one unified platform. Though the competition concludes, the connections endure. With real-world clinical practice as our anchor, Komen will bring simulation-based competitions to more regions so that technology resonates and medical professionals grow together. Together with peers around the world, we strive toward one shared goal: safer healthcare, reaching every patient.